Good morning, good afternoon, good evening, depending on what part of the globe you're in. Welcome to today's Journal Club. Of course, obviously, as always, I'd like to thank ESGO and IGCS for their support of our Journal Club. Before we begin, I always want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. The participants with cameras turned on will appear or may appear in the video recording. And we ask that everyone please keep your microphones muted so that we can all hear the presentations. If you're having any difficulties or questions, please send a message in the chat and our technical support team will assist. And then, of course, obviously, we always welcome questions, lots of questions, and we encourage you to submit those questions via the chat function throughout today's session. So this month we have a special guest, Dr. René Pareja. He's one of the authors of the lead article titled Efficacy of Topical Treatments for High-Risk Human Papillomavirus in Preventing CIN2 Plus Lesions, a Systematic Review. René Pareja is from the Clínica de Oncología Astorga, Gynecologic Oncology, Bogotá, Colombia. And I'm really very pleased to see him join us for this. René, thank you so much for participating, for sharing your time and having an opportunity for us to discuss this really interesting topic that I think is certainly relevant to many around the globe. So with that, René, I will pass the forum to you and you can provide your presentation and then we'll get on to the questions, both from the fellows and from the audience.
Thank you, Pedro, for this kind opportunity. Are you able to see my screen?
Yes.
Perfect. Thank you very much. Hi, everyone. René Pareja. I'm going to present today's Journal Club on our lead article published at the International Journal of Gynecological Cancer April's issue. This is a systematic literature review called Efficacy of Topical Treatments for High-Risk Human Papillomavirus in Preventing CIN2 Plus Lesion, a systematic literature review. There are several authors, and you can see names as Andreina Fernandez, Gabriel Levin, Nadima Buruston, Arthur Su, among them. In the clinical context, the driver was persistent high-risk HPV infection is the primary driver of cervical intraepithelial neoplasia and further progression to cancer, particularly CIN2 plus, more CIN3, but CIN2 plus. The current standard, the guidelines recommend strict observation only for high-risk HPV infection and also for CIN1 or LCIL, depends on the terminology we are using to determine the lesion. And the clinical question was, can topically applied therapies actively prevent progression to high-grade lesions such as CIN2 plus, or are they being promoted without sufficient evidence? The filtration matrix methodology included the population, women with high-risk HPV and less than CIN1, confirmed by histology or normal colposcopy. The intervention was any topically administered cervical agent evaluated in isolation. The comparator was placebo or a watchful weighted control group, and the outcome was the primary endpoint is to capability to prevent CIN2 plus. We initially collected more than 300 records, and after filtering them, we reviewed 19 of them, and finally, we considered 16 records for formal complete review, and we retrieved zero articles addressing the prevention of CIN2 plus when using a topical agent for high-risk HPV infection. All 16 trials had inadequate outcomes. Most of them failed to measure actual progression to CIN2 plus, relied entirely on surrogate endpoints like HPV clearance or cytological changes. We are going to address this during this journal club. 12 trials with inadequate population, including patients with already CIN2 plus diagnosis, lack necessary histological confirmation of lesion grade, or lack specific information on high-risk HPV. For trials with an inadequate intervention, tested oral systemic supplements or multi-therapy regimens rather than isolated topical cervical agents, and inadequate comparators such as laser cryotherapy instead of standard of care, which is placebo and observation. The verdict and the blueprint for future research is that the current evidence from randomized controlled trials is entirely insufficient to determine if topical cervical therapies reduce the risk of progression to CIN2 plus in women with high-risk HPV. The implication for practice is the standard of care continues strict adherence to observation and watchful waiting for patients with low-grade disease and high-risk HPV as recommended by major international guidelines. Medical professionals should exercise caution against the routine clinical use, prescription, or promotion of unproven local therapies for the prevention of high-grade lesions. If we keep in this track, if we keep doing this, we will need in the future oncologically relevant endpoints. The trials must abandon surrogate markers, viral clearance, viral undetectability, change in cytology, change in immunohistochemical markers, and use histological progression to CIN2 plus as the primary outcome, because the CIN2 plus, as I mentioned before, is the cutoff when some kind of treatment is needed in some patients. To have appropriate controls must include true placebo or observation-only comparators to reflect real-world standard of care. And the studies will require formal power calculation, specifically sized to detect differences in long-term CIN2 plus progression, accounting for the high rate of spontaneous regression. And this is the visual abstract. This is available in our social media, and you can scan those codes. The upper is the article, and the lower is the podcast that we recorded that is available since the beginning of this month in our social media. So Pedro, this is the material I got, and we can start with the questions if you want.
Excellent. So thank you, René, for that introduction. And before we get to the questions from the fellows and the questions from the audience, I wanted to just ask you, because obviously for our patients, information is critically important in order to make decisions. And I know that there's often claims that there are many topical agents that promote HPV clearance. How much validity is there to that? And I know that we're going to go into the details of each of these questions, but just to a patient who happens to come across this information, what is the level of evidence and validity in terms of promoting basically a cream to prevent HPV clearance?
Pedro, this is the main question we have to answer, because there is a gap in the knowledge on HPV treatment, because the patients want to do something active in order to clear or disappear or not having any more HPV infection. And all the guidelines said just observation. This is a difficult information to manage with the patients. And in this gap, those products just appear, offering a solution for clearing supposedly HPV infection. But we need to remember that the spontaneous rate of HPV non-detectability is higher than 90% at 2 years. So all those infections, the majority of them will clear by itself without any additional treatment. But the patients have fear. They are scared when receive the diagnosis of HPV infection. And the easy way is to prescribe a given product. The hard way is to take time to explain them the natural history of the condition, and the high likelihood of having a spontaneous resolution. This is the most difficult part. The patient have fear, and the clinician and the practitioner most of the times don't have enough information on the natural history of the disease, and they opt for the easy way.
Okay. Well, great. So let's start with some of the questions from our fellows. First, we'll go to the University of Western Australia. Nicole Chris.
Thank you, René. One argument for using surrogate markers like HPV clearance is that the effect of the intervention on the index infection is accurately assessed. Women frequently have several HPV exposures and infections over their lifetime, and progression to high-grade dysplasia might be a result of different HPV infection to that initially treated or that observed. Do you think it is feasible to design an RCT, say, powered to assess an outcome like high-grade dysplasia that occurs relatively infrequently and is influenced by multiple prior and subsequent events, including new infections and vaccination?
Thank you, Nicole. A well-designed randomized trial powered for CIN2 plus is certainly challenging, but it is not unfeasible. It requires appropriate sample calculations, careful selection of high-risk population, such as persistent high-risk HPV infection, which is the key element, and sufficient follow-up, because there are manuscripts with 3 months of follow-up, 6 months, and no more than 1 year follow-up. And the only study with included 1 year of follow-up is a negative trial. The key point is that methodological difficulty should not justify lowering the evidentiary standard. If an intervention is intended to modify the natural history of HPV-related disease, it must demonstrate an effect on clinically meaningful outcomes. Otherwise, we risk adopting intervention based on endpoints that don't translate into a patient's benefit.
Excellent. Thank you, René. We'll turn it over now to Leila Abulatsi in Georgia.
Thank you. So, based on your review, perhaps there was any topical specific factor agent that you are the most promising and that you would prioritize for investigation in a future randomized trial.
René, I'll repeat the question because the audio was not clear. Leila's question was, based on your review, was there any topical agent that appeared most promising and that you would prioritize for investigation in a future randomized trial?
Okay, thank you, Leila. Based on our review, no topical agent can currently be considered promising in terms of clinically meaningful outcomes. Some agents showed signals in surrogate endpoints, but none were designed or powered to assess progression to CIN2+, which is the only outcome that would justify a clinical use. Therefore, at this stage, prioritization of any specific agent would be premature and not supported by robust evidence.
Fantastic. Again, I want to ask any of you who are in the audience to submit your questions for René, but we'll keep going with the questions from our fellow. We'll turn to Ilker in Turkey.
Thank you, René. Thank you, Pedro. That was a great article, and all the scientific community needed such a clear evidence for that kind of market tragedy. And my question is that several excluded trials demonstrated improvements in surrogate outcomes such as HPV clearance and cytologic regression. Could the authors clarify whether these intermediate endpoints might still hold clinical value in selected groups, or should they be entirely disregarded in the absence of demonstrated impact on progression to CIN2+ lesions?
Thank you, Ilker. Surrogate endpoints such as HPV clearance or cytologic regression might have exploratory value, particularly in early phase research. However, they should not be they should not be interpreted as evidence of clinical efficacy. HPV infection is dynamic, and clearance does not necessarily equate to eradication of reduced oncological risk. Moreover, 4 months ago, there was a publication released by IPVS, International Papillomavirus Society, on the change in the nomenclature, and the word clearance has completely disappeared. Now we are using detectability or not detectability, because the capability of the test for detecting an HPV infection will depend in many, many things. In the threshold of the test, in the amount of active infection, the phase of the infection, if it was a recent contact, if it is a chronic one, or if it is a real persistent one. So we need to note that we already stopped about talking about clearance. We are just using detectability versus non-detectability, and this will ease our dialogue with the patient. In this context, ILCAR surrogate outcomes must be interpreted with caution, and their use should not substitute for demonstrating impact in CAN2 plus progression.
Excellent. So, Renee, we'll turn to some of the questions that are coming in from the audience. This one from Albert Jacob, and he's asking, from your personal experience and in the literature, are there any modifiable risk factors that we can address to reduce progression of CIN1 and early lesions?
Definitively not. The natural history of HPV infection is regression, whereas HPV infection is a very common condition. Cervical cancer is a rare consequence of a chronic HPV infection. So most of the infections will become undetectable spontaneously after 1 year, 2 years, 3, 4 years. And the 10% of lesions that became persistent ones, it not necessarily mean that it will become into dysplasias or cancer, because most of the women will have a persistent infection with any malignant transformation if they are followed enough time. So we don't have any intervention so far to accelerate or to improve the natural history of a disease that already has a irrelevant natural history.
Excellent. So, Renee, we'll now turn to questions from the fellow Naya Seminario from Vallebrón in Spain. She couldn't join us today. She's in a lab in Germany. So, Alvin Matthew is going to ask her question.
Thank you, Dr. Pareja. My question is, considering that in current international guidelines recommend observation for women with high-risk HPV infection and less than CIN1, what is the opinion of the authors on potential clinical role of topical therapies in specific subgroups? So, for example, patients with anxiety or limited follow-up compliance, despite that absence of high-level evidence in CIN2 prevention.
Okay, thank you, Alvin. I think this is a very relevant question. While there may be patient-centered considerations such as anxiety or follow-up challenges, current evidence does not support the clinical use of topical therapies in any subgroup. In such scenarios, the appropriate response is reinforce counseling in a honest dialogue with the patient. The patient should know the natural history of the disease, and the physician shouldn't be scary about handling an HPV infection, which is a common condition. And the physician should be able to transmit calm and to put the patient in a smooth state about having an HPV infection, because the patient should know that the likelihood of disappearing spontaneously is quite high. And the other issue is to have adherence to guideline-based follow-up, because in all the guidelines, the recommendation is to observe the patient at regular intervals during quite some time. Introducing improper intervention risks deviation from evidence-based care without any clear clinical benefit.
So, Renee, we'll turn to a question from Gabriel Levine in Canada, and Somewhat of a controversial, potential sensitive question is, do you think topical treatments for HPV perhaps have an economic benefit for industry over a standard of care?
Gabriel, this is a tricky question. I will respond as a physician responds. We are trying to evaluate the literature using the tools that science and the statistics provide us. According to that, there is no benefit of using topical therapies for any HPV infection. It's not the aim of the manuscript or not the aim of the authors to judge or to consider if someone is earning money by selling these products.
Excellent. Very well. So we'll turn back to Alvin. And Alvin, your question, Alvin here at Houston Methodist.
Thank you, Dr. Pareja. So the question I have now is related to vaccination status. So really important influence in this area is vaccinations. Did any of the papers you reviewed control or assess for that?
Thank you again, Alvin. Vaccination status was inconsistently reported or not accounted for most of the studies we consider.
Very well. And I see there's ideally if you can put your questions to the chat, but I see Jose Jeronimo who has his hand up. So if you can go ahead and please ask your question.
Oh, thank you, Pedro. And great, René, great presentation and paper. I want to go back to the comment about anxiety of the patients or the use of this topical treatment by doctors because the pressure of the patients or because with the creams, they constantly have new appointments with the patient to follow the progress of the infection. You responded clearly that, okay, the recommendation is observation, no question about that, just observation. But there is no recommendation saying do not use those topical treatments. That could be a more direct message for the doctors of patients saying, or at least saying no topical treatment has shown any benefit for clearance of the virus or any message that is much more direct. I know it's difficult, but that could be really very beneficial if those messages come from international societies.
Thank you very much, Professor. And probably we need to look forward to the upcoming material on the issue that we mentioned.
So René, another question from the audience is, what's your opinion about ablation treatment in HPV high-risk positive?
Okay, this is a completely different question. But HPV will clear by itself more than 90% of the cases. In a persistent HPV infection without any transformation or any proof that something is happening at a cellular level, at a histological level at the cervix, there is no indication for performing anything of any kind of ablation. Ablation treatment is a strategy available in very low resource settings. This condition should be treated CIN2, I'm referring to CIN2 plus and 3. With excision, just local destruction of things is reserved to very, very low resource involvement, such as vaporization, cryocoagulation, or things like that, but not intended for HPV infection, intended for some findings in the visual inspection.
Very well. So we'll turn now to Beate Sarta in Latvia.
Thank you so much for your presentation and congratulations on the lead article. I think you already touched on this a little bit, but you know that spontaneous HPV clearance is common and CIN may regress. So how should future trials distinguish a true treatment benefit from the natural history of the disease?
Thank you, Beth. This is one of the central challenges in this field. The future trials must include placebo or observation arms ensure adequate follow-up duration. It's not enough 3 months, 6 months, 1 year. Is that not enough? It's far from the natural history of the condition. And use histologically confirmed endpoints such as CN2+ at least. Without these elements, it is not possible to differentiate treatment effect from spontaneous regression, which is common in HPV infection and CIN1, as mentioned before.
Excellent, René. Another question from the audience is, I have a question regarding and wondering if you can explain the mechanism of action of the gel. Is it antiviral? Is it immunomodulatory, epithelial regeneration? Which of these is it?
Thank you very much. This is a tricky question. There are several categories. There are immunomodulators, there are microbiota reestablishers, there are even oral compounds, all of them with different mechanism of action. But so far, none of them has been registered as a medicine, as a drug. All of them are registered as medical device. And in Colombia, those products are registered under the category of medical device. In the category where the gel used for doing ultrasound is registered. It is not a medical compound. It's a medical device. That's a way to avoid the regulatory agencies and how strict this approval should be.
So now we'll turn to Gemelli Hospital and Giuseppe Parisi.
Thank you, Dr. Ramirez, and congratulations, of course, Dr. Pareja, on this very interesting work. And my question is related to what Dr. Geronimo already pointed out before. So what do you think is the biggest risk of adopting or promoting topical treatment in this kind of population of women affected with high-risk HPV infection or CIN1 lesion before robust clinical evidence is available? And how might this affect patient management in terms of over-treatment or false reassurance? So should guidelines recommend not to use this topical treatment? Thank you.
Thank you, Giuseppe, for pointing out this. The greatest risk is the normalization of interventions without demonstrated any clinical benefit. And this can lead to over-treatment of the patients, increased health costs, and financial toxicity because those things, those substances are expensive. And importantly, false reassurance for patients. False reassurance may delay appropriate follow-up, which is particularly concerning in a disease where timing of detection is critical.
Excellent. So, René, we'll turn now to Lucia Rivero in European Institute of Oncology in Milan.
Hi, everyone, and thank you so much for this interesting work. My question is about Dr. René, if you had to design the next trial in this field with adequate funding and the right population, would you invest in a new topical therapy or in these therapies?
Buenos días, ¿cómo están? Ella María.
Sorry.
Vale. Yo soy la doctora Flor, yo la voy a operar.
Can we please turn off the microphones if you're not asking the question?
Okay, or would you pivot entirely for a systemic approach, maybe, such as folic acid supplementation, for example, and why you choose one or another? Thank you.
Thank you very much. Thank you very much, Lucia. If we will have the money, if we have funding available, I would prioritize rigorously designed trials rather than a specific modality, not topical or systemic. At present, the limitation is not the type of intervention, but the lack of methodologically sound evidence. Any future strategy, topical or systemic, must first demonstrate biological plausibility and clinical impact on CIN2 plus progression. It is not enough to say that it has the capability to clear HPV infection or to treat LCIL or CIN1 disease.
Excellent. So we'll turn now to Anusha Kamath from India.
Hello. So my question is, with no eligible trials identified, how should clinicians interpret absence of evidence versus evidence of no benefit? And if that distinction should be discussed with the patients who are considering a topical HPV treatment?
Anusha, this is an important distinction. Technically, we are dealing with absence of evidence, not definitive evidence of no benefit. However, from a clinical perspective, absence of evidence of benefit in the presence of a strong natural progression should not justify routinary clinical use. This distinction must be communicated clearly to the patients. This treatment has unproven benefit and are not part of the standard of care. All the guidelines state that the standard of care is just observation, because the chance of having a spontaneous regression is just huge.
Excellent. So we'll take one more question from our fellows, and we'll go to Vincenzo from Gemelli.
Vincenzo is couldn't make it because he's in a lab,
Okay.
and so Beat will take his question.
Very well.
So, Vincenzo wanted to ask, after your work on this publication, given the high spontaneous clearance rate of HPV infection and the CIN1 lesions and the relatively low risk of progression to CIN2 plus, do you think that using CIN2 plus progression as the primary endpoint in trials of topical therapies is methodologically realistic?
Okay, thank you very much. I think yes, it is both realistic and necessary, because CIN2 plus represents the clinically meaningful threshold for intervention and aligns with established management guidelines. While it requires larger and longer studies, any intervention aiming to change practice must demonstrate impact at this level, using less stringent endpoints risk, generating results that are statistically significant but clinically relevant, as we mentioned it in our manuscript. Before finishing this part with the follow-up question, I would like to clarify that the intention of this article is not to harm or damage any particular company. It is only to evaluate the quality of the literature appropriately using the tools that science and statistics provides us.
Excellent point. Thank you, René. And René, I'm going to ask a question that, for many physicians or patients, they might say, so what if the evidence is kind of weak? What's the harm in actually just using a gel or a cream? It's not going to hurt me, so it can only help me. So why not?
Because there is no scientific proof that this is useful, because none of those compounds has been compared against the natural history of the disease. None of those compounds have been followed for years, 5 years, in order to demonstrate that they're better. One of the trials, one of the most famous, I don't want to mention any name, presents a comparison between Watson weight, so observation, versus one of the topic treatments. And at 1 year, there was no difference. There was no difference at 1 year. But authors mentioned in conclusion that was a trend on improving the result. And trend, it doesn't exist. Trend is nothing about an intervention. So once one of those products has shown that the undetectability after 4 or 5 years is 90% in the watch and wait and 100% in the treatment, I will start prescribing it. But we don't have this yet. So the risk is the patient has to pay for this. The patient are investing money. And in Colombia, this treatment can reach $300, $400. This is a lot of money for an intervention without any proven benefit. That's the main risk.
Excellent. So, I mean, Renee, obviously, it seems like this is something that is quite common in Latin America. I'd love to hear from some of the other um, fellows that are present from around the world as to how frequently is this being used or prescribed, or is this part of the standard practice? Anusha, you're from India. How common is this the use of gels to clear HPV?
It's almost unheard of. It's not much used here. Very, very only for like if somebody's conducting a study, but it's not in routine practice as a treatment. Only if like somebody's like researching it, only then it will be prescribed, otherwise not.
Excellent. And love to hear from Europe. Any of the attendees who are here from Europe. I see Giuseppe in Italy. Is this commonly used?
No, Dr. Ramirez, actually, it's not embedded in routine clinical practice, this clinical topic treatment, no.
Okay. And then one more. I'll turn to Australia. Nicole?
No, until all of these publications, I hadn't even heard of it. So it's very not mainstream here either.
So it seems like it's primarily mainstream in Latin America. Ilker from Turkey.
Yes, people demand such medications in the private practice also. And for the academic hospitals, mostly we don't suggest these kind of medications because, as the literature says, there's no clear evidence. But in some private practice, some doctors use that prescriptions because the patients also demand such kind of things for rehabilitation, maybe for rehabilitation. We know there's no difference, but it's quite prescribed in private practice.
Interesting. And actually, I see many comments now coming in. I see Fernando Heredia saying in Chile, these are sold by the shelves and not by prescription. So basically, Fernando, in Chile, patients can just go to the pharmacy and buy it. And then I see some additional comments. Teresa Pan is also, at least in Europe, Congress last month, there were quite some talks about it. Teresa, you want to expand on that?
So not really precisely, but it's something that has been talked about quite a lot, and there were also quite some poster, of course, not totally self-funded. So yeah, who knows what come.
Yeah. Renee, I wanted to ask you, and kind of this was actually the AI question from the podcast that we did, and I'd like to just hear your thoughts again on it. Should the gynecologic oncology community push back more aggressively against the commercialization of topical HPV treatments? And I should repeat, this was the question that was generated by AI.
Pedro, I think we have as a scientific community, we have the responsibility to inform not only the patient, but the physicians about the weaknesses of the treatments that are being prescribed. So I'm not trying or becoming a leader on promoting a movement against some things. We need to understand what is proven and what is not proven regarding clinical benefit. And none of those treatments has proven any clinical benefit. They just take advantage in a hole in the natural history of the disease. When you ask a patient, you need to do nothing, and some companies can say, don't wait, do something. Just acting against the guidelines. My recommendation is to follow the guidelines and to be aware that the literature should be interpreted and read cautiously. And according to the literature, there is no any single product able to clear HPV infection or CIN1. And none of them are able to prevent CIN2+. That's it. That is my final message.
Okay, and René, I think this encompasses several of the questions, but one of the questions is, in low-income settings where many patients don't have access to ablation or excision, how do you see this fitting in somehow, potentially helping patients? How does this potentially fills that gap?
Yes, it's a good question. When we have a good evidence, a level 1 evidence admitting that those compounds already work, the strategy of the WHO organization is that says 90% of the girls should be vaccinated before the age of 15, 70% of the women should be screened at 35 and 45 years, and 90% of the women with dysplasia or cervical cancer should receive proper treatment. It will be a 4 pillar. 100% of the women will need a cream to prevent HPV progression. But we don't have that information yet. Until we have this information, we should consider this as useful interventions.
Excellent. Well, René, I want to thank you so much for obviously providing an outstanding journal club. I think at one point I saw up to 145 people who joined for the journal club. Oh, I see one additional question before we close. Chimtai Mungo.
Yeah, hi. Thank you. Most people don't know me here. I am a general OBGYN, so I'm not a gynecologist, but I work in dysplasia prevention in low resource settings. And I want to sort of invite first, thank you so much, Dr. Pareja, for this wonderful presentation. And as was mentioned, so I put some things in the comments. So my colleagues and others have NIH funding to study one of the topical therapies that has randomized trial data with biopsy confirmed data. So I think part of as fellows really want to think, right, is there an absence of evidence or poor evidence? And then what are the trials? What are the characteristics of trials that should make us confident in being able to potentially add a fourth pillar? So I want to encourage the trainees to really, as was mentioned, trials that have short endpoints, that don't have biopsy confirmed data, that are not randomized, so let us as a community define what that evidence is, so that when you tell your patient that this gel doesn't work, that's being pushed by a pro-profit company, we can even communicate to them, and at the same time, let's embrace the possibility that there might be evidence in the pipeline. And what can that be? It's rigorous biopsy confirmed data at baseline. Do you say, what's an important disease we want to treat? Let's say biopsy confirmed CIN2-3, because we know 30, or even CIN3 or P16 enriched CIN2 and CIN3, because we know 30 to 50% will get cancer. If you work in Kenya like me or Malawi, many women who had treatable dysplasia were walking around for years because there's no leap. So we can't, and their governments are not training 100 OBGYNs right now, 1,000 to get leap. So for us to get to 90-90-90 or prevention of death from a very treatable dysplasia, we need to find urgent ways to address that. So let's, if our health systems cannot train well-trained OBGYNs to do excisions, have electricity in 5-10 years, can we have rigorous trials for therapeutic vaccines? Can we have rigorous trials of topical therapies that have data? We have, we're studying the microbiome. We are studying, again, let's I think define what's rigorous. So we have very good, two pathologists agree that this is P16 enriched CIN2 plus CIN3 at baseline. They're randomized as a placebo control. We have adequate checkpoints so the person in the placebo doesn't get cancer. Of course, we know CIN3 doesn't become cancer in 6 months or a year. So, for example, right now there are therapeutic vaccines trials in progress that will observe under placebo a CIN3, because we know that if we can treat a CIN3 with a vaccine, we're going to save so many women's lives. I live in North Carolina where I practice as an OB/GYN, and here it's very rare to see a woman with cervical cancer. If you go to Kisumu, where I work, in Malawi, the ward is full of like stage 3 disease, fistula, etc., because there's no leap, ablation only works so much. So anyway, I'm clearly passionate about this, but I want to, so same way that self-collection for HPV self-collection, probably 30, 40 years ago, folks would be like, what? Like, that's crazy. Let's open our minds. Let's really define what's the rigor, and then let's, be able to evaluate what's rigorous and potentially not throw the whole baby with the bathwater, which is an American saying. But basically, are there ways that we can use the science? I posted there's Antiva is a drug company in the US, clearly has a profit motive, but at the SGO meeting that just happened, published what I think most of us would say is relatively rigorous trial. So let's keep our eyes on what's out there, because our patients really might benefit from it. Thank you.
Thank you so much for
Thank you, Dr. Mongo.
comment.
Thank you.
René, any closing remarks?
Yeah. We need to use the evidence-based approaches for decreasing the mortality due to cervical cancer: vaccination, screening, and treatment. There is no room for topical treatments without any proof of success. Bias and flawed manuscript, surrogate outcomes, P16, detectability, things like that. So we need to trust in science, and we need to offer evidence-based approaches. Thank you very much for being here.
Excellent. Well, thank you so much, René. Thanks to everyone who joined to listen to this discussion, to be part of the Journal Club. I want to thank the fellows for putting together their questions, and of course, obviously, always thank the IJGC and ESGO for hosting this Journal Club. And I also want to remind everybody to join us for the May Journal Club to discuss the article titled in Gynecologic Oncology, Feasibility and Safety After 1 Year Implementation by Lucia Ribeiro. So with that, I want to thank everybody. It was great to see everyone join, and have a wonderful rest of your day.
Thank you very much. Bye-bye.